Okay, I think we're gonna get started here. We have an awful lot to cover, and I see that people are still rolling in, so we'll just welcome them as they come in. So an official good evening and welcome. I'm super pleased that you could join us for tonight's discussion on children and health. Like I said, we have a ton to cover, so I will very briefly introduce our speakers and then we'll dive right in. So to kick things off, we're joined by Dr. Val O'Hara. She is a dual certified pediatrician and obesity medicine physician who recently joined knownwell to expand our teen care program. Dr. O'Hara has been practicing in Maine for 25 years as a primary pediatrician, and then since 2009, focusing exclusively on pediatric obesity care. She was an early leader in bringing this care to families virtually, beginning telehealth services back in 2015. And that is Dr. O'Hara. You can hopefully see her there on your screen along with our slides. I will briefly introduce myself. I'm a registered dietitian. I have been helping individuals and families make delicious and healthy food choices for more than 20 years. I am also a parent. Okay, I'll kick this over to Dr. O'Hara and she will get us started.
Great. Next slide. Thank you so much for all of you who've taken the time this afternoon or this evening, depending on where you're joining, to take a moment to join us as we talk about Childhood Obesity Awareness Month, which we'll touch upon. We'll look at the current prevalence of obesity in youth and teens. We're going to share our knownwell whole child approach and really also thinking about care without bias and stigma, really non-judgmental supportive care. We want to think about the patient and the parent's voice and how to be a good ally with both of you when you come and meet with us, and really offering this full spectrum of care for the whole family. So it is towards the end of September, which is the National Childhood Obesity Awareness Month, which is a great opportunity for us to really celebrate the many progresses that we've seen over the last 2 decades, certainly since I started doing this work, looking at childhood obesity as a chronic disease with more tools, more research to support each family, but still at the same time pushing for continued improvement in obesity care, really particularly around access. Our goal is really to provide resources and education and compassionate, comprehensive whole child care, right, across the age of all children of all ages so that they can grow healthy into healthy adults. We also want to think about advocacy for access to all treatments, including from prevention and interventions. Oftentimes we hear in childhood obesity discussions that it's all about prevention, which is vitally important, but we also have to be mindful of the teens who are struggling with this diagnosis now, and how do we get full treatment for them. And our goal in particularly about Childhood Obesity Awareness Month is to reduce bias and stigma in healthcare and across multiple sectors. And a key point of that is really providing education about the disease of obesity, that's a chronic disease. And much of this is at the subconscious level and not in anyone's fault, but really taking away that bias and stigma. And if we can do that, we can work towards a healthy, bright future for all of the teens that we care for. So sometimes a good place to start is to say, well, how common is childhood obesity? What does that prevalence look like? And the most recent data shows that about 1 in 5 teens and children are living with obesity in the United States. That represents between 15 and 21 million children are struggling with this diagnosis. What we also know from the research, unfortunately, is that the fastest expanding subset of that is children who are struggling with higher levels of obesity or more severe forms of obesity, and that we're seeing it in even younger children. And if we think about this globally, over 300 million children and adolescents are struggling with the diagnosis of overweight and obesity. And so if we know the challenges there and the prevalence, we also want to say, well, how easy is it for us to access care? And we know it's difficult for adults. It's harder even for children. Less than 1% of children and adolescents who qualify for interventions actually ever get that treatment. A publication that came out earlier this summer, it was about 0.4%. So again, this month reminds us that there's more work to do in getting treatment into the hands of patients and families who need that. And that's one of our main goals here at knownwell. Next slide. So approaching metabolic health for all ages, right? We used to think about this as, oh, children will grow into their size, and this is a problem for adults. But we know that obesity is a chronic disease, and it oftentimes starts in childhood and adolescence, and it's a complex chronic disease, right? There's a lot of science that we're learning, and our job is to share that with you, that this is not a personal failing, that there's a lot of biology, there's lots of systems our body is created to protect against starvation. So we have a lot of systems that our body is trying to maintain that energy. So the biology is really important, and we're learning more about that. We also are learning so much more about the genetics, how we can be more precise in terms of defining what might be different for one patient to the next in terms of that heterogeneity of the disease of obesity, how genetics plays a huge role. And when we have the biology and the genetics, which is not in my conscious control, then we have the environment on top. So sometimes we say our biology and our genetics sets the table, but the environment serves the meal up. So there's lots of triggers that are in our environment that we want to target collectively to help improve health. So our known well approach is really coming at it from a family-centered and health-focused approach for all of our families. This is a great image that was from the most recent American Academy of Pediatrics recommendations that came out a few years ago in 2023. And it really does outline a lot of the contextual factors that get in the way or influence health and treatment around the diagnosis of obesity. But it really highlights that treatment needs to be comprehensive and lifelong. So it starts on the left with really that patient family as the unit, and all of us who are here in healthcare to support them in their journey across the lifespan, and that the care needs to be longitudinal. It needs to be first and foremost non-stigmatizing care. And unfortunately, we know a lot of families have already encountered that in healthcare. We know that it needs to be a shared decision-making process. And in order for that to happen, we have to have the opportunity to share the most recent data about those treatments and how effective are they. And if one treatment works, then great. If it doesn't, we need to get our heads together and figure out what else we can do. We know that treatment intensity and support will vary to address the relapsing and remitting nature of this chronic disease. We also know that children are developing and growing into adolescence, and that's a dynamic time too. So we need to be flexible in meeting families where they are. And because we know this is a chronic disease, we have many more treatments, which is super encouraging, but we don't have a cure. So we need to plan ahead. And as older teens are moving into adulthood, we need to start planning about transition of care. And that's a vital part of any chronic disease management for our teens that we will focus on when we are working with families as well. So this is a picture of a brain. We're not going to have a science quiz today, but the brain and energy regulation is so important to really highlight, again, that a lot of this is at the subconscious level, right? There's a whole host of hormones in our body that decide to inform us from our periphery. It gets information from our intestines and our fat cells and our muscles and our pancreas and our stomach. All of these messages, when we are taking in energy, are coming into the brain. And I call it coming into my metabolic brain, and is being processed there to help us know if I've taken in enough energy, if I feel full or not. I have my thinking brain where I'm working with Dom and the team to make healthy choices and healthy meals and maybe work on my sleep. But then we also have the reward brain, right? Where something looks good, smells good, tastes good. And there's crosstalk between all three parts of the brain that then tell us whether or not our body's going to hold on to energy or give it up. And those mechanisms are really, again, redundant to protect against losing weight. So we can understand why it takes a team and comprehensive, thoughtful care when we're taking care of this diagnosis. We know too, this is an opportunity this month in particular to really validate and acknowledge that obesity is stigmatizing through life. And some important work that's come out of the Rudd Center and people like Dr. Rebecca Poole have researched this extensively, that unfortunately we see children as young as 3 and 5 years of age who've experienced negative weight stereotypes beginning in preschool. They can have a sense of being treated differently because of their size. So we know that that starts really early, unfortunately, for a lot of our kids. And these stereotypes worsen, leading to teasing, bullying into elementary and middle school. Kids experience it from their friends, their family members, their teachers. And then this carries on into adolescence for some patients, where that continued bullying, we know from all of these sources, can affect their psychological well-being, their social well-being. But we also know that bias and stigma affects our metabolic health as well, with increased inflammation, chronic stress, and increasing risks for things like diabetes, for example. So we need to be mindful and acknowledge the major impact that this has. And we see weight bias can become institutionalized later in life and can represent itself as discrimination in terms of employment, healthcare, and education, and it carries on into older adulthood as well. So again, that comprehensive longitudinal approach is so vital. So where does bias happen? As you can see here, it happens in a lot of different sectors. There's lots of research, particularly looking at the healthcare setting. You can look at the action study or the action teen study that really highlights that oftentimes teens and adults who are living with obesity experience less time with their healthcare team, lower quality of care, and less coverage for obesity care. We also know that as kids are in school, they oftentimes experience lower expectation and less supports from their teachers. There's reports that up to 40% of teens have experienced bullying or teasing by their PE teacher or their coaches. And we know a bulk of their time is spent at school. So we really need to work again to advocate and educate around this diagnosis. And we can see this can carry over into interpersonal relationships and how kids feel about themselves in terms of neglect and shame and internalized bias. It's also there in the media, and there's so many aspects of media that children are engaged in, but we know that there's still a challenge in terms of negative stereotypical portrayals of this diagnosis in terms of the language they use or the visuals that they use. So again, we need to be comprehensive, and September as Childhood Obesity Awareness Month is really having an opportunity to call that out as well. So the impact of weight bias and stigma, again, it's unfortunately widespread. It affects people across all areas of life and across all ages, as we saw, as children as young as 3 and 5. We know it to be harmful because it's linked to emotional, social, and physical consequences. And we can see it can be reinforcing and creating negative feedback cycles and internalized bias. And we want to replace that with positive reparative visits with our teens and really focus on the fabulousness that is each and every single one of you. And we know that bias and stigma can be very unfair and leading to inequitable care and poor outcomes for people living with this diagnosis. So we talked about the many advances, we talked about prevalence, we talked about bias and stigma. But what happens when we don't treat obesity? Many years ago, and still now, sometimes I encounter colleagues who will say, well, children will grow into their size. But we know from the AAP guidelines that came out, we cannot have watchful waiting because we know that oftentimes the disease is here. And when we delay care, it's poor outcome. So what happens when we don't treat? So we know there's increased risk of prediabetes and type 2 diabetes. When I trained 30 years ago, type 2 diabetes was a grown-up problem. But unfortunately, we're seeing it now even in our children, and perhaps even a more difficult to manage type 2 diabetes when it presents earlier in life. We see increased risk of cardiovascular disease with higher risks of high blood pressure, up to 30% higher prevalence. We see 3 times higher risk of abnormal cholesterol levels. We see higher obstructive sleep apnea, 45% for children and teens who are living with obesity versus 9% without. We can see NASL, which is a big term, but basically it's liver disease that's related to obesity. We see that even in young children now. And obviously, we are very much aware of the increase in psychological distress that many children and teens are experiencing with this diagnosis, where 32% increased odds of having or developing depression for children who are living with obesity. So if we take all of this collectively, we can understand why this is oftentimes associated with a decreased quality of life. And our goal here is to reframe this and take it out of that shame and blame and really look at it from a medical perspective in a supportive way and applying the science. So what are our goals for pediatric patients with overweight and obesity? First and foremost, we want to continue to encourage those healthy habits that you're already doing, work on improving them further, and thinking about lifestyle patterns throughout adulthood. So I say we want to work on goals that will keep you healthy till you're 105. As a pediatrician and a mom, that's what we hope for. We want to improve health quality, right, over time. We want to work on that body composition so that you can do all the things you want to do. We want to treat and or prevent future health consequences that we know travel along with the diagnosis of obesity. And ultimately, we want to improve that body image and self-esteem of every single teen that we encounter. So our knownwell team looks at the whole child across development because we know there are different factors at different times of each person across the lifespan. We know there are things that might be different for a child who develops obesity younger than 5 at puberty. Our job is to kind of work with the family to learn about those individual journeys and things that are unique to each child. We also want to think about age-appropriate screenings that are tailored to each child. We have those recommendations from the AP that I talked about, but also from the Obesity Medicine Association and in terms of our pediatric algorithms to help guide that care, making sure that we're screening for any comorbidities that would be important to care for the patient. And we want to support families with strategies that grow with your child and are dynamic and flexible as each child's journey is different. I love this image on the side, right? This is from, again, the AP clinical guidelines, and it has the patient and family in the center. And all of your known well team is around to support all of your efforts and work. And we come at it as obesity as a complex chronic disease. And the AP guideline certainly outlines that each child needs a full evaluation, including screenings for related complications like obstructive sleep apnea or prediabetes and things like that. And we know that treatments are most effective and safe when they're provided by a team of pediatric obesity specialists. And our known well team here is to provide the best evidence-based care. So we apply science, the best science that we know, right? And what we have learned over these last 2 to 3 decades is that it takes all of these to put together to really make a comprehensive care plan. And we know lifestyle is important for a lot of chronic diseases, not unique to obesity. We know we want to work on lifestyle to be well. We want to treat and prevent worsening illness. We know it's important for diabetes and hypertension and obesity. And many times patients have come to us and they're doing a great job working on all of these and still feeling a little bit stuck in the mud. And what I love about the biology and the science is now we can start to target that physiology that might not be working. And when we can put that with your lifestyle, I call it like supercharging all of our efforts for best outcomes for improved health for every single teen that we work with.
Thank you so much, Dr. O'Hara, for that review. I feel like I learn so much every time I attend one of your webinars, and I hope the families out there feel the same way. It's certainly complex, and here at knownwell, we are looking at it from all directions with professionals who are compassionate and collaborative, like Dr. O'Hara. So I mentioned before, if you joined us at the top of the hour, that my name is Dominique. I'm a dietitian, and I've been working with individuals and families for about 20 years. Um, and I go back and forth when I'm working with my patients, my clients, and I say, it has to be delicious. I'd like it to be healthy. It has to be delicious. I'd like it to be healthy. And so for all of you out there that are thinking, oh no, now we're going to hear, slides about how I have to eat peas or broccoli or green beans. Well, if you like peas, broccoli, and green beans, awesome. Yeah, those are some of the foods that we know to be healthy, but there are so many healthy foods. And you can see the slide says there are no bad foods. And let me explain that a little bit more. We're most healthy. We get the most out of our bodies. And I'll come back to that in a second. When we eat a healthy food pattern. So it's not so much, did I have a good food or a bad food? Do I eat all healthy foods or all, foods that don't support my health? It's about a whole combination of choices that together do all of those things that Dr. O'Hara talked about. So I'm going to ask you for a second to think of this phrase that I think we probably all heard. It's a little bit old-fashioned. You are what you eat, right? You are what you eat. And that's actually literally true. I won't throw too much science at you, but if you think about it, is your skin made of the foods that you eat? It is. It is. Are your taste buds made of the foods that you eat? They are. What about your brain? The stuff that's, participating right now and listening to this webinar. All of the cells in your body actually come from the foods that you eat. So rather than thinking, oh, I'm eating a good food or a bad food, or I'm on a program or I'm off a program, which kind of can get us really into a tizzy of feeling like we're being judged or judging ourselves, even worse. Think of it as you are what you eat. So let me give you an example. Every 120 days, you have a whole new set of red blood cells. Even if you're not a doctor like Dr. O'Hara, that's pretty meaningful. And the foods that you eat contribute to those brand new red blood cells that do all sorts of things, including allow you to run up a flight of stairs or play in the playground because they bring oxygen to the cells that need oxygen in order for you to be able to do that. What else? Every 9 days, you get a whole new set of taste buds, which allow you to eat those foods that are delicious that we like so much. So, when you're thinking about foods and the foods that you're choosing or that are being put on your plate or you're being told are healthy for you, just remind yourself, I am what I eat. And so, if I eat a selection of healthy foods, I will be a healthier body for it. We're going to take a look at a plate, which some of you have seen. So I invite you back to it for those of you that have seen it before. For those of you that haven't seen it, I'm a super visual learner. So if I can picture something, you can talk to me all day long with words and I can read books and textbooks. But if you can give me a picture of something, it stays in my brain. So I'm going to ask you to take a look at that picture. You've got fruits and vegetables on one half of that plate and grains, and I'll define each of these in a second, and proteins on the other half of the plate. So it doesn't have to be as complicated as how many grams of this or servings of this or even calories of this. Scientists and food scientists get really in the weeds with that stuff. For the rest of us as eaters, all you really have to remember is that I've got fruits and vegetables on one half and grains and proteins on the other half. So think to yourself right now, I'll give you a couple of seconds and feel free to put it in the chat if you like. What are some of my favorite fruits? Well, I love apples. I love bananas. I love grapes. They're super easy. I freeze them. I love strawberries. I love pears. So I could go on and on. There are no bad fruits, right? How about vegetables? Okay, this one can be a little tougher. I've worked with plenty of people that say, I don't like any vegetable. And somehow in there, I've been able to find a vegetable or a way to prepare a vegetable that you can work with your family on or a dietitian if you're in our care. So that includes carrots, it includes corn, it includes spinach, it includes lettuce, it includes radishes and cherry tomatoes and cucumbers. All of those are perfectly delicious vegetables that you are what you eat will become all of those healthy cells in your body. Grains, it's a little bit of a confusing name. It's really anything that is made from a grain or a grain. So things like pasta and rice and quinoa and couscous. We also kind of throw in there, it's a little bit messy, things like potatoes because they act more like a grain in your body. And then there's those proteins. What are proteins? What are your favorite proteins? Mine are steak and chicken and fish and sometimes tofu if it's prepared really well. Ooh, we're getting some in there. Brussels sprouts and baby spinach and salmon. Absolutely. So all you need to remember is I'm going to design that plate and then have a side serving of a dairy or a dairy alternative if you don't tolerate dairy. And that's your plate. That's really all you have to remember. You don't have to think about like I said, grams or ounces of something. Just think about that plate. I'm looking at the chat. So, oh, I love pinto beans too. We've got beans, we've got salmon, we've got baby spinach and Brussels sprouts, figs, yum, and watermelon. These are such great foods. One of the things about being a dietitian is we're always hungry because we're always talking about food. And now you guys are giving me all these wonderful examples. So you are what you eat. That's what I'm leaving you with in a way that when most of the choices are healthy, we end up with a pretty healthy, well-functioning body. And the way to remember, well, how do I design my pattern that Dominique said was so important? We've got fruits and vegetables, we've got grains and proteins, and we've got a serving of dairy a dairy alternative. And that's really all you need to know to start designing a healthy food pattern. And hopefully we get to also take care of you, the dietitians here at knownwell. I think I toss it back to Dr. O'Hara for a review of this slide.
Great. Awesome. I want to go to your house and have dinner with you, Dominique. It sounds so delicious and it can be fun and exciting. And I love that our taste buds are refreshing, right? So what we didn't like when we were 5, we might really like now. So
True.
Retraining our taste buds is always exciting. And so again, we're here to build your teen's health journey all together as part of this team. And we're really trying to make it precise for you. And it involves all of these aspects of care that you see here, right? We're going to work with our teens towards positive health choices and really helping them understand why we're asking to make any changes, right? And I think sometimes it's helpful to go back to that brain and say, well, if I make this change that Dominique just said, how does that affect my body's ability to manage my glucoses? And how does that change my cholesterol? If I sleep better, how does that give me more energy? How does my body repair? So all of the goals that we work on, we can tie them back to your overall wellness and health. And as Dominique talked about the nutrition and really tailoring that to you to emphasize balance and those patterns is so important. And we want to help guide those decision making for those teens and families together and really supporting the behavioral side of this care. And this does include pharmacotherapy. We have a needle there, but there is both injectable and oral medications that we can use when it's appropriate to improve metabolic well-being for our teens. And there's FDA approved medications. There's medications that can target other parts of that physiology that we talked about. So we can start to really be strategic with each of you to meet those needs.
So I'm going to ask you guys to jump into the chat if you can find it on your phone or your laptop, wherever you're joining us tonight, and share some of your health goals. They are so unique. I think of snowflakes because that is just a super special version of each of us. So for some people, it might be playing a game like soccer or a playground game with friends. For others, it might be limiting soda. That when they drink a lot of soda, they feel like they've got a ton of energy, but then they sort of feel a crash and they would like to limit their soda or they're concerned about their dental health. Riding a roller coaster is not for me, but I know for a lot of people. And so that might be a perfectly legitimate. I just want to jump in a ride and feel comfortable in that space. I want to move my body more. I just want to move more and feel comfortable and not feel so breathless when I move around. We've heard from patients that they have a whole family history of a particular condition, like diabetes, their grandparents and then their parents. And so that child and the whole family really at that point is committed to trying to turn that around. And adolescence, childhood and adolescence is a wonderful place to start to address that. Improve sleep hygiene, sleep better so that we have more energy and focus the next day, eat more fruits and vegetables. That's one that's obviously near and dear to my heart.
Mhm.
I'm going to read some of these that are coming into the chat because they're really extraordinary.
Very good.
Improve
Yeah.
self-esteem. We hear I'm having more energy. Learn how to take care of the body responsibly into adulthood. That's beautiful. So addressing today for tomorrow is exceptionally poignant. Find more veggies I like. They're out there, I promise you. And part of it's preparation and part of it is just keep trying until you say, oh my goodness, this one is not one I thought I would like, but I do like it. Um,
Right.
so there are loads and loads of health goals that you guys are sharing. Each one is super important. At knownwell, we talk about finding your why or focusing on your why. And that's really what we're talking about here tonight is what is important to you and your family about making choices for a healthier present and a healthier future. Learn to love my body.
I
Beautiful.
love that. Yeah, I think that's the most important part of our visit when I first meet a family is what's really most important to you in this moment. Life is changing, right? And we need to be respectful because all of your reasons for improving your health are validated and important. And our job is to support you to get there. And so I love all of those comments and such feeling comfortable. Yeah, those are all great, great, great goals. Some of our goals at Known Well is to be a really good ally for you, teens and young adults who are having this diagnosis is really to really work in partnership and work alongside you, right? Honoring your each individual journey, as Dominic said, your each individual snowflake, right? Your own journey. And really to use respectful language, asking what words are you most comfortable with when we're talking about this diagnosis. This is very personal, and we need to be respectful of that. And sharing, taking the time to share the understanding and the science that obesity is a health condition, it's not a choice. right? And we know there's lots of things that are at play. And we want to make a very safe, welcoming space for every patient. We want to rebuild that trust if you've had a negative experience to really replace it with a lot of positivity and some fun at the same time. We do look at the whole child, and weight is only one part of that health metric. Part of our job is to take a whole history and a whole assessment of all aspects of your health and your care and your family and your dynamics. All of those pieces are vitally important. It's not just about a weight on the scale. And our job is to really support progress and to help you set those achievable goals and really provide real world strategies to make and help them implement. And then really to celebrate all of your health focused goals, right? Those are the most important. And again, we know obesity doesn't happen in a vacuum, and certain things might take priority. We need to be providing care that is flexible and meeting those shifting needs from a mental health, physical health, emotional health. All of those are vitally important, and we need to be able to be flexible in meeting you in those moments. And we also want to be a good ally for parents, right? No child or family should ever have to manage any chronic disease, including obesity, on their own. And so we really want to acknowledge past experiences that parents may have faced blame for their own diagnoses or their child's obesity. And our job is to really undo that and replace that with science and facts and support. We want to offer positive supportive care and repair those encounters if you've had a negative experience. And really, again, meeting you where you are and sharing the science in clear, respectful ways that make sense. We want to honor parents as experts on their child, right? We know parents want the best health for their kids, and we want to be with you in partnership on that journey. And we want to engage and share decision making that's guided by science and supported by a whole team here at knownwell to get you from those whys to success. Because we know every child and teen is unique, and we want to engage, and we're here for you in all shapes and sizes for sure.
We do have a few minutes for questions. So I would love, you guys have been so engaged in the chat so far. I would love if you could start to throw some questions in there. I can curate them. I can throw them to Dr. O'Hara or try to answer them myself. They can be anything from related to lifestyle that we've talked a lot about, how we achieve those goals that you guys put in the chat, what the medication choices are that are out there. There's so much in the news today about that topic, and I think it can probably be at times confusing or overwhelming. Here you have the experts to talk to you about that. So feel free to type them into the chat and we will read them as they come in. Here's one, and yeah, keep them coming. We have a few minutes, so please feel free. This is why we're here. We want to share information, but we also want to answer questions. Can you compare statistical likeliness of overcoming childhood obesity with and without intervention?
Oh, that's a really great question. And we know from a lot of data more recently, particularly in childhood obesity, that when a child has obesity as a child or adolescent, it has a very high likelihood of tracking into adulthood without intervention. And we know from the data, now we have 15 plus years of looking at intensive lifestyle therapy as monotherapy, which is part of the American Academy of Pediatrics guideline. How effective is that? For some people, if you have that phenotype, you can respond, and that's great. Well, you know from the data, that's about 3 to 7% of the population who will respond to intensive lifestyle therapy alone. And so when that piece is not sufficient to the disease burden, then we want to add more interventions, and that includes medications or metabolic bariatric surgery, which we have a couple of medications that are FDA approved for kids 12 and older, and a few for even younger kids, those very slightly more rare genetic forms of obesity. We have medication called setmelanotide for kids 2 and older. So I'm happy to go over those as well.
I'll read this one. And if we don't